Good morning. Thank you so much for the update. So as you heard, my name is Dr. Victoria, a pharmacist. And I think Cohen had engaged us on a couple of things that we're covering today on the healthcare financing. And it is a very important pillar of UHC because even if we empower our healthcare providers, we create facilities, we make them top-notch, but if the population can still not afford healthcare, then we really have helped them. So, just to engage you in a few, I believe most of you have heard this multiple times, that so many Kenyan households are just one medical bill away from being impoverished. And just to put a number to this, it's about 2.6 million Kenyans today. They were, if they encountered a hefty medical bill, they would be impoverished, which is a huge number. It's about 6.2% of Kenyans. And this is why our discussion today is going to be very important. And as we had discussed previously, as youth, we have to get ourselves a seat at the table. I remember someone saying, if you're not offered a seat, then you have to bring a folding chair and put yourself at the table. So, for plenary discussion, we'll be having very, very amazing members. Starting with Dr. Lyndon Marani, who works for, amongst other things, Open Phences. Please welcome him. We will also be joined by Dr. Cynthia Wambui, who works for the Clinton Health Access Initiative. Okay, so I'm informed that she will not be joining us, but we'll also be joined by our very able convener and founder of Ryculture, Dr. Odhiambo. Thank you. We hope to have a very nice, flowing discussion. So, as we have seen, healthcare financing it's definitely a major thing here. And as a youth here, first of all, uptake of healthcare insurance, whether it's the National Hospital Insurance Fund or the private health insurance, but it's pretty good. And some of these factors is because we as the young people believe that we're at a lower risk of getting ill. Yes? So you feel like if I get ill only once in a year, why should I get healthcare insurance? Yeah? So as you give us our opening remarks, please give us what do you think about the uptake of health insurance in Kenya in general? Thank you.
Thank you. So, for me, to start with healthcare finance, one of the key things when we talk about financing is to understand that it's about resources. And we have limited resources in every other context that we're dealing with. And those resources, either it's workforce, there's financing, in terms of training to the end where they deliver the services, there's payment in terms of employment of the employee, there's infrastructure and all that. Then now when you talk about healthcare financing, the most critical area that we look at is insurance as a mechanism of ensuring that people, whenever you call a rate, you're able to get services that are paid for by the insurance company. So as young people, definitely most of us are not taking insurance, but when you look at it even from a national scale, there was a statistic I was reading somewhere in this, like we have less than 30% of the Kenyan population on even social health insurance and NHIF. So how then can we drive that number? But at the same time, when you look at the Kenyan population, the young people between 14 15 to 35 based on the African Union age gap, then we see already even more of our Kenyan population are young people. And if most of our Kenyans are not having insurance, then young people are not insured. So how do we drive that engagement and how do young people taking up insurance? And I think the starting point would be to understand, why don't young people take insurance covers? And what are the challenges we're having with these insurance solutions that are presented that are not lucrative or that are not interesting for young people? Why would they not want to take a health insurance scheme? Problem. And those are the key discussions that I think we'll have.
Thank you.
Thank you very much, Victoria. First of all, just to introduce the organization I work for. It's called Phences. It is based in a university, so it's an acronym. We have to do long one to prove to you that we are highly educated. So Phences stands for Public-Private Healthcare Engagement and Collaboration and Hospital Policy. Those many words just simply say we want the public and the private sector to work better together to deliver healthcare for communities. Jumping straight into your question about youth not taking up insurance. I was having this conversation. Can I speak loudly enough? Can you hear me? Yes. Okay. Okay. Yeah. I was having this conversation yesterday with my 17-year-old. Yeah, I'm not that old. I started very young. And I was asking him, why do young men make the best soldiers? The reason young men make the best soldiers is because they believe they're immortal. They believe they can't die. They actually believe that if you shoot them, they will somehow survive. It is that belief in the fact that I will not get hurt, I will not get sick. That is the basic reason why young people don't take up insurance. I, on the other hand, have some realities. Every time I look at the mirror, my stomach reminds me I'm not as fit as I used to be. I now realize that I might be at risk of diabetes. I realize, and it's because of those risks that I take insurance. However, all sorts of insurance cannot work unless those who are at lower risk take up insurance. In the US, for those of you who remember Obamacare had to force young people to take up insurance by forcing them to pay extra if they did not take up insurance. So that's a negative inducement. It's negative in the sense that if you don't pay, you will be charged. So is that a direction we want to go as Kenyans? Probably not. We probably have to think up of different reasons to entice people to take up insurance.
Okay, yes. So,
Just
to direct this to the audience, I mean, most of you here are young. Just by a show of hands, how many of you have a form of health insurance, be it NHIF or any other personal private health insurance? Just briefly by a show of hands. Okay, and one that is financed by you and not by your parents. So I think that's less than half. So yeah, I think even from the demographic area, you see that generally, yes, there's a disparity of the outcome. So what are the kinds of incentives that we may give the youth to help them improve the uptake for healthcare insurances other than paying out of pocket?
This is a difficult question because if somebody had cracked it by now, somebody would be doing it. It's global. It's not just a Kenyan. It's not a Kenyan problem. I've given you one example. In the US, they use a negative incentive, where if you don't take up insurance, then you're forced to make some extra payments elsewhere. But the true answer, in my opinion, to the youth taking up insurance is to get them jobs. Because because it's easy for us to figure out how to deduct money from your salary than it is to actually tell somebody to pay from their pocket. It's just not the youth. Even us who are we're much older. If you ask me to every month take out insurance from you, it would probably cost something like 15,000 shillings a month. If you tell me every month diligently to put 15,000 more, that's hard. But when it's removed from my salary, that is much easier. So the best route to provide insurance for the youth is to employ the youth, then use the same methods you use for removing your taxes, NHIF, NSSF, blah, blah, blah. But there are other ways. Probably there are tax incentives we could give to young people that if you pay for insurance, that amount of money is removed from your tax. Huh? It's taken from your, what do you call it, pre-tax income, tax deduction. Or saying that if I've seen money back insurance schemes where you pay and it's a saving, and if you do not use it at the end of the year, it gets back to you. Those are potential schemes that could be used. How applicable they are in our environment is what I don't know. If they were applicable, somebody would have tried them by now. So unfortunately, it's a very difficult question.
Actually, just to add to that, the fact that generally, I hope you can hear me. Yes. So generally, when you look at the dynamics of it, yes, people will not take up insurance because paying the money out of pocket is a challenge. But at the same time, you need to ask yourself, what is the value? You buy something because you see the value that comes with it, right? Who buys anything that they don't have use for? Almost no one, and nobody will ever do that. So the question is, what is the value that you're associating with an HIF or any other insurance scheme? And that is, I think, one thing that from an innovative perspective, we can look at how do we then configure this. And I remember in terms of some of our recent discussion within culture and organization, we're asking ourselves then, how do we see the gaps that are coming with insurance? A young person will tell you, the NHIF cover as it is would make me, if I'm unwell and I go for inpatient services, they will cover for most of the care needs that I have. For outpatient, it will be like, let's say up to 500 Kenya shillings, which means that might only cover for consultation, and the major bit is to buy medication. The other case is, if I'm unwell, I don't go to the hospital where I seek consultation from a doctor, but I go to a pharmacy to buy medication that I think will treat me. But the NHIF cover is not enlisted within the community pharmacy. So ultimately, whether I'm paying 500 per month or not paying 500, I'll still go pay an additional amount of money to buy the medication when I'm unwell. So do I have a need to pay for it? Most likely not. Because I don't feel I'm never going to use it, because the only critical area where it will help is when I'm admitted. And the chances of me being admitted, as we're saying, young people feel like we are admitted, we can't get sick, we don't get to the point of being admitted. So how do we then incentivize the aspect of innovating to ensure the insurance covers can be covering people and accessing services even in the outpatient facilities and even in the pharmacy setup where I can buy medication from a pharmacy, and that will be paid through the healthcare insurance scheme. And those are some of the options that I think could also be looked into, other than incentivizing young people to take up the cover that they need to take.
Thank you.
So, you had mentioned in your discussion that one of the ways to enhance the youth uptake would be to employ them. Yes? But you find that most of the people working in the informal sector are the youth. So yes, some of them might be employed, but in the informal sector. Generally, in the informal sector, most of the people come out in general, you don't have a place, yes? You're paying your money in cash. Take this. So, how really will you go about deducting this money that I have collected in cash from my employer, or will you go about it by making sure everyone is paid through certain, just engaging them?
That's very interesting. The government has been trying for a very long time to figure out how do you bring the informal sector into the tax bracket. One thing I have to give to the current government, I believe the current government is working with Safaricom to develop insurance products which you can pay like Fuliza. Is that true? Is it Antiba? Yeah, I would really love to hear what that scheme actually looks like. Yeah? But that's one scheme you can use very easily in our environment. It doesn't matter whether you're formal or informal. Typically, people are on M-Pesa, one way or the other. We also know that even those of you who have done construction, you pay people using M-Pesa. At the end of the day, you just send money to the foreman, then the foreman distributes it. The government has to come up with strategies of being able to identify that kind of income. Even for the informal guys, even in
can we look at formalizing so that, let's say, for example, before this auditorium was set up, there is the contractor who got the job. There are the people who are doing the construction or actually subcontracting if there is. Then they have their employmentee, or these are the manual laborers who are going to support in terms of masons and all that. Then it now becomes kind of a contractual agreement that we know for the period what are the stipulated timelines and the project management plans. Then over that period we know Victoria will be working at this particular site, even if it's just supplying food or whatever it is, for the period of 3 or 4 years. For that period, you are working at this particular site, your compensation rate is said to be 300 shillings or 500 shillings per day. And therefore, at the end of the month, whether you are paid on a daily basis, we know that your employer, the contractor or the foreman, has to deduct a particular amount out of that to pay for your health insurance. And also provide provision for occupational hazard and all that. Because normally it's in the policy paper, but it doesn't apply at the point where you need to process a claim. So how do we look at that? Because that actually will ensure that the informal engagement and contractual employment is now being formalized and people, the labor rights are actually respected for the employees. I think that would be another aspect.
I actually think that would be. So this is a challenge. Hopefully, policy, lobbying, maybe we will go into that. Dr. David had mentioned something about the terms of insurance. Yeah? Insurance, for example, NHIF does not cover for palliative care. Is there something we can do as healthcare professionals to maybe make health insurances more community?
I think making insurances more comprehensive would be the idea. But the question is, from a social insurance scheme like NHIF for start, definitely that would be good to have it comprehensive because at the end of the day, it's a government program to serve the general public. And therefore, the scope of services should be integrated and also the rebate or the compensation levels should be established based on what are the costs of offering this service. How many people in the general public would need such a service and would be willing to have that within the cover portfolio of what they're going to get at. So from an NHS perspective, that would be a policy agenda that we look at from that dimension in my perspective. Then on the other end, from private insurance, one thing you have to know that private insurance is business. And the aim of business is to offer a service that people are willing to pay for. How many people in our general population, as we understand, are able to pay for palliative services or actually need the services first? So how many people need palliative services? Those who need them, are they able to afford these services? Are they able to pay the cost? And if so, then how are they paying for them now? With an insurance option, will it be cheaper or will it be more costlier for them? With that, then they're able to design a package that they know have a sizable market group, is able to raise a substantial amount of money, and in case they are going to actually pay for that particular service when it's necessary, then there is an active population. But if it's catered for, let's say, for example, palliative service in an insurance cover, the premium will be higher. The general public who might not have a need for that would kind of be pushed back. I don't have a need for that. Why do I have to pay for it? But then for the people who will want the palliative services to be integrated into their cover are people who actually need the service now. And the business of insurance is to hope that if I'm insuring you for a particular disease, we hope you don't get it, so that I don't have to pay the money. And that is how I'll make the money. So if I know you definitely already are sick and you need to be getting the services, it's like you're paying for the service but paying it through me. Is that going to be good business? And those are the kind of dimensions that need to be looked at.
Mine is very simple. You want palliative care to be part of the insurance package, get all the youth taking insurance. If you get all the youth taking insurance, all 15 million of you, we have enough money to take care of all palliative care in the country.
Yeah, that's a very interesting point of view. Let's just divert a little bit here. We're talking about healthcare financing. Already there are costs that are in healthcare, where the direct and indirect costs. So this direct cost, the cost of actually going to the seeking the service, the medical product, is there a way, other than insurance, yes? Is there a way we can lessen these costs, and how do we implement these ways?
Is there a way we can reduce costs in healthcare? No. Sorry, bad news all around. Is there a way we can reduce costs of healthcare? No. Why? Because the technology we are using to take care of people is only getting more and more sophisticated. The cost of inputs is being affected by the same inflation that is there in the general economy. Doctors are about to go on strike again. Why? They want higher salaries. Kenya will pay better salaries than literally any African country I know, save South Africa. A Kenyan intern makes more money than a cardiologist in Ethiopia. Can I repeat that again? A Kenyan intern makes more money than a cardiologist in Addis Ababa. Are our cost of care going to come down? No. We have modeled our healthcare system against the West. Yeah? And they believe in providing more and more and more healthcare. Crazy statistic. 1 in 8 of all human beings in the Netherlands works in healthcare. 1 in 8 of all human beings in the Netherlands works in healthcare. So will our cost come down? With our current model and the way we are going, the answer is very simple. No. Our population is aging. When I was your age, our life expectancy because of HIV had dropped to 52 years. So when I was 26, I only had 26 years to go. Now, our age, for someone of my social demographics, my life expectancy is what? 80. If you put me in the general public, it drops, yeah? Because of HIV and everything. But if you take me in isolation, you look at people like me, 70, 80 is a very real possibility. Do you think it's going to cost any less to take care of me from here henceforth? No. So I do not see the cost of healthcare coming down unless, this is something we're talking about, Dr. behind that, unless you guys in this generation figure out a completely different way of offering healthcare services to Kenya. You have to completely, radically rethink how healthcare is being offered. Our current system where if I get sick, that's why I go to hospital, does not work. Does not work. The current system where NHIF is paying for sick care, NHIF does not pay for health. There's no insurance in Kenya that takes care of health. All insurances in Kenya take care of sickness. That is sick in itself. We have to figure out how do you get healthcare to make sure you do not get sick in the first place. And it's very easy. I look around you, and some of you can already tell in 5-10 years, you'll be coming to me for diabetic care, potential care. Yeah? So since I already know that, can somebody already start thinking of a mechanism where instead of you waiting to pay 200,000, 300,000 in premiums 10 years from now, you start paying 30,000, 40,000 shillings in premiums consistently over the next coming 10 years? People of my generation are benefiting too much from the current healthcare system for us to come up with some of those things. Sorry about that. But the lady who was here before mentioned that the Kenyan healthcare space is worth 400 billion shillings. Huh? How many of you are medics? Okay, good. We only have about 15,000 doctors in Kenya. Divide 450 billion by 15,000. That's about 30 million per each and every doctor. Do you feel as if you control a space worth 30 million? So there is something fundamentally wrong with our healthcare system. And we are not going to give you the solutions. I'm benefiting too much. It's up to you to come up with ideas.
That's a great challenge in the sense that our care, and actually that reminded me of some conversation we had with Hezron and Kay through Planet Wizard Media. It's like, how do we give information that keeps people healthy than taking them care of them when they are sick? Because we are sick care but not health care. And everybody, even now when you're talking about health, you're talking about health from a point of you are sick, you need care. Somebody is sick, they need care. We need hospital. Hospital don't treat healthy people. That's a fact, right? And even when you look at our financing, we are talking about the figures and the finances that are there. Every MCA in your community wants to build a health center. And that was part of the promise they gave, right? That is a fact. And the MP is also looking at building another health facility. The governor promised to upgrade the level 4, level 3 to be a level 6 hospital. So we are going the infrastructure way. But as much as we're going the infrastructure way, have we identified the healthcare challenges that people are at risk of so that we address them before they become challenges? And those are gaps. And making healthcare cheaper and affordable would be about looking at how do we prevent sickness. Because if we have less sick people, we need less hospitals, which means we are spending less money to build hospitals. If we have less sick people, we need less money to buy medicine. But as it is, that is not going to be the case. And therefore, then the other bit in healthcare is, healthcare has become a consumerism model of business. More people are consuming everything they can get, therefore they're getting sicker over time. And because they need better quality services, and we associate quality with the cost of care, then I'll set up my clinic next to Amref at the door there, and put it as Prime Care Odhiambo Clinic. And being Prime Care, you'll find a dispensary which is government owned next to at Langata there, and you'll be able to pay, let's say, 100 bob to seek care there, right? But at my clinic, I'll make it 1,000 bob. And let me assure you, out of 50 people in this room now, only 10 might go the other side. The other 40 will come to me because they associate higher cost with better quality. So for me, that is what I offer you. Then the next thing would be, if you come to a hospital and you're told, by the way, I don't think it's recommended for you to take this medication, you'll be like, hapo sikutibiwa. Zara sikupewa dawa, sindio? That is the normal narrative. Even in our village, sikupewa dawa was not treated. But when you come and they give you 7 sets of medicine and advise you how to use them, you feel treated and you feel taken care of. So are those 7 medicines cheap? No. Because at the mindset, you need more medication to feel that you're being treated, not being kept alive and healthy with the least possible intervention. So the intervention model is making us consume more, and as we consume more, consuming more comes with more investment in terms of cost. And that is how we need to be thinking.
Can I jump in? It just reminded me, sorry, I'm in love with numbers. Huh? I want you to do a mental experiment. Mombasa to Malabo, yeah? I want you to draw a parallel line to that road. That line should be 100 kilometers north of it and 50 kilometers below that road. the Mombasa-Malaba route. What proportion of Kenya's population do you think lives in that strip? It's actually our entire population. It's actually our entire population. We live in a very narrow strip across the country. Guess what? Because of something called CDF, and because of counties, I can bet you less than 5% of Kenyans living in that strip live more than 5 kilometers away from a healthcare facility. We're one of the first countries on the planet to have achieved that. In Homa Bay, a place, 33% of all girls between the age of 16 and 19 are mothers. 33 are mothers. Yet, no one of them is more than 5 kilometers away from a healthcare facility. So are those healthcare facilities working? Challenge to you. Of the 55 primary healthcare service centers in Homa Bay, about 16 to 25 of them are not functioning. The government cannot afford the staff and the consumables that are needed to operationalize those centers. And that story happens over and over again in so many countries. To those of you who are looking for work, put together a proposal. Give it to USAID, give it to DFID, give it to GTZ, give it to anybody. Get a group of young Kenyan medics to go and take care of those facilities. Now, will that work? I don't know. Will the governor accept that? I don't know. But that is the kind of crazy thinking that we actually need. I'm sorry, I'm a medic, but I am not a very good, I'm not a proponent of our union. We're the only professionals who actually unionize. Have you ever heard of architects going on strike? Have you ever heard of accountants going on strike? No. But when clinics, how many of you remember something called clinics? The network, it's not called what? It has a new name. It is a network of almost 200 primary care facilities across the entire country. It was being sold, and it was advertised in the newspapers that it was being sold. So I was actually asking some of our colleagues, under KMA, can't KMA buy a network of 200 clinics? If you take 1,000 doctors, write their names and they say we will work at these places. Upeleke James Mwangi at Equity. Atakata. Let's think radically. Don't think about anything that is normal. The youth are very good at thinking of the abnormal. Take advantage of that.
Thank you. And the words of someone who I can't remember say that it's the crazy ones that change the world. So yes, think crazy, don't think inside the box. And I'm being told we're running out of time. So in our parting shot, I think during this discussion, something that has really come up is prevention. Working, actually being a healthcare rather than a sick care. So together with your closing remarks, kindly tell us, engage us on, right now, the average Kenyan will not even seek health services when they're ill. They'll say, it takes, you will wait for it to become so bad before seeking health care. So how are you going to tell this person to just go to hospital for a routine check, go to seek the services of a nutritionist or any healthcare provider to improve their health rather than treat them? This is a person who will not go to hospital unless they are almost bedridden, yes? So how will you incentivize these people to seek health preventative measures? And yes, please tell us that as you give us your closing remarks.
Well, I will start. The first question would be, why do people go to hospitals? Is it because they have other pressing priorities? and what are those priorities? Because once you establish that, then you're able to understand why is it that I don't go to hospital. I'm one of the victims, and I know it's good to be honest. I go to the hospital when it's really, really necessary. And for me, the reason would be, I have other things that I feel like I need to do this and I need to do this. But it's a mindset. I think from a social behavioral aspect would be, for me to be able to function optimally and doing everything that I need to do, then I need to be at the best healthcare status. So that would be one of the drivers, to make me actually see that I need to ensure that I go to the hospital and to stay healthy. But beyond going to the hospital, preventative doesn't mean that I have to go for checkup. Going for a checkup is already suspecting that I'm doing something wrong. So the first bit would be, do I have access to the information to make healthy life choices? And if you're able to make the information and the knowledge to make healthy life choices, then I'm adopting them, then probably I'll be at my best. If I'm at my best, then I don't need to go to the hospital even for the checkup. If I do, once in a while, and it still be working well for me. And that would be a key thing. And that is actually when I'm linking that to the incentivizing healthcare financing options, I'm like, can we have a way that we are making healthy living a lucrative and more appealing thing to the young people? And then we make it be like, if you adopt these healthy practices, you'd get an incentive in the form of tokens. And these tokens would be linked to your NHIF. So if this person doesn't smoke, doesn't drink, or doesn't drive recklessly and all that, whichever option, even if you limit your drinking, whichever it is, then the package is that for this, then you'll get a token. That token will be redeemable in your next healthcare visit, even if you go for a medical checkup. Or if you are unwell and you need care, it will be sorted. Then that means we'll be more healthy. If we are healthier, then do we need to spend so much money when we're sick? Most likely never. So that is how I would look at it.
Thank you. Thank you.
Sorry, I had to laugh at that. Basically, you're saying that if you do not leave, in other words, you don't do any of those vices, you will get better and better healthcare. That's what I have to do. Community health strategy. I personally believe we cannot, as a healthcare system, sit back and wait. We have to be a little bit more proactive. We have to come up with a nyumba kumi for health, where we have healthcare workers who literally come to you, ask you those questions, and proactively give you the information that you need. For anybody who amongst you can think of how to make money from that, there's a couple of billions waiting for you there. I'll repeat that again. For avoidance of doubt, the person who is going to figure out how to use the community health strategy to proactively take care of the population, there's a couple of billions waiting for you right there. In my closing, we have, is it 2,000 now, unemployed doctors? And everyone is telling young people, employ yourself. I have tried opening businesses and I can tell you, it's hard. It's not easy. But the best time to do it is when you're young. Why? I have 2 kids in private school. Risk is not something I want to do, but I still have to take it. And it's hard. But when you're younger, it's easier because you can fail, get up, fail again, get up again, and then you survive. If you need money to start a business, I'm sorry, there are only 3 places you can get money. Friends, family, and fools. The only people who will give you money to start a business is friends, family, and fools. Yeah? Up until a business is actually a good enough idea, that is the only time you will get funding. The only sources of funding we have for healthcare in Kenya are government. We were shown that slide on the last slide, the lady who was doing the abstract. She was calling it social what? No. There's a funding mechanism where the government can actually give money to CSOs. Social contracting, yeah? How many of you have access to people who can get you social contracting? However, don't lose hope. If you have a good enough idea, network, 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 network. Don't get tired of networking. Don't get tired of selling your idea. One person will listen and they will understand what your idea is. I will close with an example. We're in the middle of COVID. Things are horrible. Those of us who have studied Biasharas, I studied at Biashara on September 1st, 2019. I started a business. Guess what happened 3 months later? Kilumana. Yeah? But in the middle of that, I'm called by the Kenya Healthcare Federation to help this young doctor who has started a very interesting idea. It's lockdown, we have curfews, but mothers are still giving birth. There are no maternities to take them to hospital to give birth. Many of you know what I'm talking about, yeah? She started up a very simple idea. We need Ubers and Bolt to keep on moving. We need women to keep on going to hospital. Talked to 3-4 people, went to the Kenya Healthcare Federation, sold the idea. She won a couple of awards the other day. So do not be held back by the idea that you don't have money. Just make sure you have a damn good idea and network until somebody listens to you.
Thank you very much. I think this has been a very insightful session. And please, if you're sitting here and you did not raise up your hand when we asked about the health insurance, this is a challenge to you. At least seek health preventive services if you're not going to get your health insurance. I am not here to market any health insurance, but I am here to make sure you're not going to get poor the next time you're trying to access healthcare. Thank you very much to our very able panelists. Please help me give them a round of applause. Thank you. Do we?
Okay, so, sorry.
Okay, another round of applause to the panel. I also